Good afternoon, everyone. Welcome to the 2021 Medicare Advantage Virtual Summit and today's panel focused on the intersection of benefit design, social determinants of health, and treating Alzheimer's disease and dementia. On behalf of the Better Medicare Alliance, I'm very pleased to kick off this important panel discussion on how Medicare Advantage is uniquely situated and able to identify and treat patients with Alzheimer's disease. I'm Greg Gierer. I'm the Vice President for Policy and Research for the Better Medicare Alliance, where I lead the public policy function and on behalf of BMA and over 160 allied organizations. BMA advocates to strengthen and protect the public-private Medicare Advantage program. Specifically, we engage in the legislative and regulatory process by advocating for public policies that strengthen and protect the Medicare Advantage program while ensuring access to high quality and affordable care to all beneficiaries. The focus of this panel is on the complex challenges facing patients with Alzheimer's disease, as well as related forms of dementia, and the critically important role that Medicare Advantage plans can play in improving the diagnosis and care for this vulnerable patient population. As it relates to benefit design, Medicare Advantage plans continue to offer enhanced benefits to beneficiaries, including increasingly non-medical supplemental benefits such as meals, nutrition, transportation, and in-home support services. According to recent research by Avalier, more Medicare Advantage plans will offer such services, meals, transportation, in-home support and services at a $0 premium next year in 2022. As you know, MA plans also continue to design and implement innovative care programs aimed at addressing the health care needs of some of the most vulnerable and frail patient population, including a program being highlighted today that focuses on the needs of caregivers. We are very fortunate to have with us today a distinguished panel of experts who will share their insights and perspectives on this critically important topic. I want to now turn to some of the introductions here. First, let me introduce John Wiecha, who is the Medical Director for Senior Products at Point 32 Health. That is the new name of the combined organization of Tufts Health Plan and Harvard Pilgrim Healthcare in Massachusetts. Dr. Wiecha's long and illustrious career includes 2 decades of research and teaching at Boston University School of Medicine and 23 years of practicing primary care at Boston Medical Center, a leading patient safety net provider serving the needs of a diverse patient population. Dr. Wiecha received his medical degree from Stony Brook University and completed residencies in family and preventive medicine at the University of Massachusetts Medical School. He earned a Master of Public Health also from the University of Massachusetts in Amherst. Our next panelist is Kelly O'Brien, who's the Executive Director of USAgainstAlzheimers Brain Health Partnership, a comprehensive initiative to promote brain health and improve early intervention. In this role, she's the strategic lead and director of the team implementing the early intervention and brain health program. Kelly's diverse experience and leadership skills have resulted in an impressive record of success in raising the profile of leading nonprofit organizations, including the Kennedy Forum, the United Way, and the American Public Health Association, and achieving positive results. Earlier in her career, she worked as a senior legislative aide to Senator Richard Durbin and Congressman Jerry Kletchko. Our third and final panelist is Sandy Markwood, who is a nationally recognized policy expert for aging issues and a passionate advocate for ensuring older adults have access to the support services both in their home and in the communities. These efforts have focused on combating social isolation among older adults, encouraging healthy aging, supporting caregivers, promoting livable and healthy communities, and ensuring access to affordable transportation and housing. Sandy has over 30 years of experience in the development and delivery of aging, health, and human services in counties and cities across the United States, including serving in leadership role at the National Association of Counties. She holds her bachelor's and master's degrees at the University of Virginia. So following the formal presentations, we'll turn it to a Q&A session, but what I'd like to do now is turn it over to our first speaker, Dr. John Wiecha.
Well, thank you so much, Gregory. It's certainly a pleasure to be here. And thank you so much for inviting me to share our experiences at Point 32 Health with what's really a very novel approach, I think you'll see, to supporting caregivers and our health plan members with dementia. Next slide, please. I'll review a little bit about who we are and how the support system works, and then discuss a little bit about the impact on caregivers and their loved ones, our members with dementia. Next slide, please. As mentioned, Point 32 Health is a recent combination of Harvard Pilgrim Healthcare and Tufts Health Plan, both nonprofit health plans here in New England. Next slide. The Point 32 Health name refers to, and is inspired by points on a compass. There are 32 points on a compass. It really speaks to our critical role in guiding members through their healthcare journey. Next slide. So as a combined health plan now, we're serving over 2.2 million members in 5 states in New England, a variety of health plans and lines of business, obviously including Medicare Advantage and Medicare Supplement as well. Highly rated health plan from NCQA, as well as 5-star rating for our Tufts Health Plan Legacy Medicare Advantage plan. Next slide. So I just want to notice all of these data we'll be presenting are preliminary, and they're based on an evaluation of a program implemented in our what we call Legacy Harvard Pilgrim Medicare line of business, and it's a program that's still in process. Next slide. So a little bit about the problem that we're working to identify, and as noted in this slide. Next slide, please. As noted in this slide, certain conditions require a much higher level of caregiver support. And 3 major examples are listed here. Obviously, dementia, stroke, Parkinson's disease being excellent examples of those. 15% of Medicare Advantage members have at least one of these conditions, but collectively, they're driving a huge proportion of hospitalizations, over 40%, and a very large proportion of readmissions to acute care hospitals, over 53% of readmissions accounted for by one of those 3 conditions. We also know that dementia is a cost multiplier on other modifiable comorbid conditions. Challenge for the health plans are conventional care management strategies are unfortunately somewhat less effective for these conditions. Some of these conditions lack really effective treatments. These are not really conditions where the member can self-manage. That's often a primary focus of care management interventions, is on self-management. And particularly with dementia, members who suffer from dementia are often difficult to engage in care management strategies. So what happens is, of course, the burden often falls on caregivers. And for dementia, we know that caregivers have higher rates of physical and mental health disorders, stress, anxiety, depression. So we're constantly looking for more effective ways to better support caregivers so that they can support their loved ones and achieve the kind of quality outcomes we're looking for without undue cost on the caregiver in terms of physical and mental health impact. And I can say on a personal level, having had a father who passed away from Alzheimer's, I can confirm the incredible stress associated with this and my own lack of support during this particular journey. Next slide. So dementia is very much a health equity issue and very much related, increased burden on underserved populations. We know that Black and Hispanic populations have a higher risk for developing dementia. Blacks 2 times that of whites, Hispanics 1.5 times greater risk. And the minority caregivers for those members and those patients are more likely to be responsible for providing home-based caregiver services and more likely to report worse physical health associated with those activities. And then compounding these challenges, they're also more likely to have low health literacy in those populations as well. So whatever strategies we're proposing to address these issues must be sensitive to these issues. Next slide. So given the need for caregiver support and the benefits that we're seeing particularly lately with COVID, the benefits of remote communication and support strategies, and the development of really ever more sophisticated technology, we decided to pilot, test in collaboration with a vendor by the name of Ceresti. Ceresti has designed a tablet-based caregiver support system that we've decided to pilot with them. So how does this work? Caregivers are given a tablet, an app preloaded with a variety of functions, and for simplicity, with no internet access. The tablet provides a number of caregiver support functions. It provides educational content on dementia. It allows reporting of member-patient status on a day-to-day basis. And it supports communication with a dedicated coach who's trained and has expertise in supporting those caregivers. It only requires about 10 minutes of use per day. It's very easy to use, and it is used at no cost to the caregiver or members. The objectives are really listed here, and ultimately, through these activities, really designed to promote the concept of self-efficacy. Now that's down the lower right, but self-efficacy is a key health psychology construct that underlines effective health education and behavior change. So these educational and support functions of the program are designed to really accomplish the things listed here: improve relationships with a loved one, obtain support from a coach, learn to better manage the chronic conditions and behavioral issues that arise with dementia, and detect problems early to hopefully prevent emergency room visits and hospitalizations. Next slide. So again, the two primary objectives are, next slide, please. And one more. So two primary objectives: improve caregiver effectiveness via education and coaching, and hopefully reduce patient hospitalizations through this remote monitoring process. As I mentioned, the application supports the educational activities, supporting submission of assessments of the member done by the caregiver, and then communication with the coach for support. The coaches are available and respond quickly to questions, requests for support, or in response to concerning assessment data that might have been submitted by the caregiver. And the educational content is actually tailored directly to that caregiver and member and is customized to each member's individual characteristics. In terms of reducing hospitalization, predictive analytics provides the caregiver and coach with information related to the highest probability complications that this member is likely to experience. And likewise, the educational content is specifically tailored to that member, with the objective of helping the caregiver to understand what are effective preventive strategies for my loved one. Things like early signs and symptoms that could be addressed to help prevent escalation. How to avoid an ER or hospitalization. When's an appropriate moment to contact a healthcare provider or the coach. And ultimately, guidance on how to access referrals to other services that may be appropriate. Next slide. So this is what it looks like. It's very simple interface and with prompts for content areas to review, daily plan, a messaging app, library, contact facilitation, etc. Very elderly friendly menu and interface. Next slide. The tablet, the application, shows a daily recommended schedule of activities, so very simply and clearly structured, including educational content recommendations. Next slide. And a very simple interface for achieving a daily assessment, which is a key to early warning of developing complications and conditions to facilitate early intervention to hopefully prevent emergency room use or hospitalization. The data that's entered from these queries is sent to a coach for review. Again, the domains are new medical concerns, new medical events like emergency room or doctor visits, and a series of questions on any behavioral concerns that may have developed. Next slide. The coach sees the summary on a control type panel, and this display of the data that's entered allows the coach to prioritize members who represent opportunities for early intervention, again, ideally to prevent escalation of these problems. Next slide. The caregiver can communicate with the coach either via telephone or using a messaging application built into this tablet. And that's something we're all familiar with, I think, how that appears. Next slide. So a little bit about, next slide, about what we're seeing in terms of outcomes and impact. So far, we've had about 164 caregivers and members with data enrolled through this pilot. And we're seeing a very high rate of monthly engagement. Over 93% of those enrolled are engaging at a monthly level, 65% weekly, about 40 minutes per week engagement among those who are users, and over 2 assessments on average are being completed per week. Over half of the caregivers are spousal caregivers. Next slide. This pie chart shows how users engage in the program. Bulk of the time is actually educational content being accessed, then coaching, then completing assessments and messaging. And the digital therapies category, which is the last category in the colored boxes, there is an interesting category. These are psychosocial therapies that are actually designed to be delivered to the member, him or herself. They deliver music, videos, and engagement content from an era from where the member still has memories. So things like movies and songs from maybe in the 1920s, 30s, 40s, and 50s, et cetera. Next slide. So if we look at impact of this approach on caregivers, one metric being tracked is the so-called mental unhealthy days, which is a CDC metric that measures how many days during the past 30 days was your mental health not good. So among the sample who completed a 6-month engagement, you see a pretty significant drop in those number of days reported by almost half over the course of the pilot, from 6.4 to 3.3 days. Very significant impact. Next slide. In terms of program satisfaction, this so-called Net Promoter Score, that's a measure of willingness to recommend a product or services to others, often used as a proxy to gauge overall satisfaction. And we're seeing a very high proportion, 78% of net positive promoters. Next slide. And a few examples of more qualitative feedback from users that really, I think, illustrates how useful this is to folks. I don't feel like I'm alone dealing with this disease. I think this is a godsend. I'm so grateful for this program. I feel supported, etc. Next slide. And one more. In addition, there's emerging preliminary evidence that total medical cost is reduced compared to a 3-to-1 matched set of controls. We see a 53% reduction in total medical expenditures, 80% reduction in admissions compared to the controls, a 42% reduction in emergency room visits, and a really large reduction of 73% reduction in readmissions. So in summary, we see this program as a well-designed, very engaging, easy to use, and highly rated approach to supporting caregivers. Our preliminary data suggests it may also impact utilization and cost, and we'll continue to run out the pilot and examine additional processes and outcomes data. So thank you very much, and I'll turn it back to Greg.
Thank you very much, Dr. Wiecha, for that presentation. Let's kick it over to Kelly.
Hi, Greg. Thanks so much for the opportunity to speak today, and I really appreciate Medicare Alliance's interest and willingness to have a conversation around Alzheimer's and dementia in particular. And I'm excited to have the conversation with my colleagues on this panel. Are my slides available? There we go. Thanks. Next slide. So just really briefly, a little bit about Us Against Alzheimer's. Us Against Alzheimer's was founded about a decade ago by a group of people who were directly impacted by Alzheimer's and dementia and frustrated with the pace of progress, or rather the lack of pace of progress. And very much, I think, the spirit of the name Us Against Alzheimer's, we operate from a perspective of this is going to take all of us. We are a very collaborative organization, and we work very collectively with community-based organizations and others, in particular, Sandy, who's on this call as well. And I wanted to mention that at the very beginning of our founding, one of the things that our founders did was create a network, a series of networks of organizations that could represent various communities that were particularly impacted by dementia. So Latinos Against Alzheimer's, African Americans Against Alzheimer's, Women Against Alzheimer's, faith leaders. So from our founding, we've been grounded in the sense that this is going to take all of us. Next slide, please. And that's really important because, as John mentioned, this is very much a health equity issue. In addition to some of the astounding statistics about the number of people that are living with Alzheimer's, I think what's really important to remember is by 2030, nearly 40% of them are going to be Latino or African American. And currently, 60% of people who are living with Alzheimer's are women. And again, just reiterating a really important point, most of those people, most of the caregivers in this country are women and women of color. So addressing this is particularly important for these communities. Next slide, please. At Us Against Alzheimer's, we want to attack this disease from all sides. And so we've been strong advocates, of course, for increased research and treatment and care for Alzheimer's, but also for prevention and risk reduction and early detection. And that's the component of our work that I'm going to talk a lot about today, because I feel like the opportunities there for Medicare Advantage are great, and it's often not discussed. Next slide, please. And part of the reason that we're focusing both, if you will, on the left and the right is that over the last couple of decades, there's just increasing evidence around the potential to someday prevent, perhaps, but at the very least, reduce our risk of dementia. There's been hundreds of studies. This is an old statistic. There's probably way more than this about the risk factors for dementia, things like depression, social isolation, physical inactivity, nutrition, and co-occurring conditions like diabetes and hypertension. And most recently, next slide, most recently, or perhaps most cited, was the Lancet Commission study that came out in 2020 that mapped 12 risk factors across the lifespan for dementia. Again, common risk factors for other chronic conditions, but things like physical inactivity, depression, hearing loss, nutrition, it goes on and on. And so I think the point that the opportunity here that's really important for Medicare Advantage is that these are often benefits that are offered in the supplemental benefits packages in many of the plans. Next slide, please. And we know that with this information, and perhaps in spite of this information, we know that most people aren't having these conversations with their doctors about how to reduce their risk or having a cognitive assessment early. A recent poll that we did by our A-list showed that 92% of people spoke to their doctor about Alzheimer's only after a diagnosis. Talk about stage 4. And this is really shocking, despite the fact that most people actually believe, you ask patients and adults, they believe that it's important to have their memory checked, but only 16% of them do. Primary care physicians believe that, and they say it's important to assess older adults for cognitive impairment, but most of them don't. So there's a distinct gap here in the opportunity for intervention and what's actually happening and the demand. Next slide, please. And just to kind of bring that home, AARP did a recent survey that I thought was really interesting. And this particular slide is focused on Hispanic Latino adults. But what it showed was that if people knew that addressing some of these risk factors like physical inactivity and managing stress and getting better sleep could improve their cognitive resilience and reduce their risk of dementia, they'd be more likely to do it. And since we're all trying to get everyone to do these things for multiple reasons, not just dementia, but for other conditions, to me, this is an incredibly powerful opportunity to ensure that we're connecting the dots between the opportunity for risk reduction and dementia. Next slide, please. So one of the ways that we've begun to do that is to meet this demand really for information and this early side of the point where people are asking basic questions. Am I at risk? Should I be worried? This is in my family, what should I do? Or I think a loved one I have in my family may have this condition. There's so many questions that people have and really no opportunity for good information quickly. We developed a tool called Mybrainguide.org. Next slide, please. And basically what this does is provide an opportunity for people to take a brief memory questionnaire. They can do it via phone or on a web bot. And that leads them to some tailored resources that are very specific to their particular situation. Next slide, please. So you'll see from this next slide that this has not even been out a year, and we've already, actually this number 123,000 questionnaires taken is low. It's probably more like 150 at this point. People have been very receptive to this. Most people are taking the web-based questionnaire. They're taking it for themselves. And some people are taking it for loved ones and having a good experience. We've gotten some initial really good feedback about this being a very helpful tool, but it really is very much the first step in their journey. And it really does need to connect to clinical care. So next slide, please. So on the clinical care side of things, it's one thing if the patient goes to the doctor and says, I took this memory test and, I have some concerns, and hands them a piece of paper. It's another thing what the response of the clinician is. So we've stood up a provider leadership group that consists of many of the provider serving organizations like the American Medical Association, American Academy of Family Physicians, nurses, et cetera, I could go on. And this group has overseen a series of work groups that have developed some recommendations really focused on clinicians. This particular set of recommendations is in press. It will be published soon, but it provides clinicians with more concrete guidance about how to have conversations about risk reduction with patients. So if you're doing a cognitive assessment, if you're doing a brief assessment, and there is an asymptomatic person or patient that you're working with, there is still an important opportunity to talk to them about the kinds of things they can do to reduce their risk. Case in point, I'm 54, I go to my doctor, my father died from this, everyone in my family on my dad's side has it. I say, I'm worried, I have APOE4 gene, what should I do? And my doctor says, oh, you're fine, don't worry about it, you don't have any symptoms. Well, that's not the right answer. The right answer is let's take a look at your health habits and discuss how you're sleeping and eating and exercising and other things that maybe we could optimize to help reduce the risk of dementia. Next slide, please. And this is all really important, I think, because a lot of new Medicare Advantage plan flexibilities have become available over the last number of years. So there's additional opportunity for a broader provision of supplemental benefits not only around things like memory fitness or brain fitness, physical activity, meals, etc., but also things that address some of the social determinants of health. So I think there is a really interesting sort of gap and opportunity to connect the dots around some of these additional plan offerings that promote healthy aging with dementia and Alzheimer's. Next slide, please. So case in point, this is just a listing of some of the things that Milliman did about the most frequently used supplemental benefits. And you can see that a lot of these things on here, hearing and fitness, et cetera, are things that address risk factors for dementia. And likewise, some of the other supplemental benefits around transportation and home-based care are also things that support families who are dealing with dementia. So there is an incredible opportunity through Medicare Advantage that perhaps doesn't exist in other places to address some of these issues around early intervention. Next slide, please. And in addition, there's financial incentives, right? So there's new financial incentives to appropriately diagnose for dementia. And so now we have financial incentive to diagnose, and we have potential treatments, right? Treatment not only in pharmacological treatments, but in risk reduction interventions as well. Next slide, please. And this is really important because the fact is that even though the Medicare wellness visit exists, only half of Medicare beneficiaries are using it, and fewer than a third of them are actually having a structured cognitive assessment, which is one of the benefits of the Medicare wellness visit. So most people are not getting cognitively assessed, even though this is a benefit that they are entitled to. And those assessments are taking place in a very subjective manner. They're not required to use a validated tool. That is something we are working hard to change. It can be done based on a conversation that clinician has about how do you feel you're doing, you know, and asking the caregiver how is this person doing, as opposed to an actual validated test that is logged and recorded in the EHR. That said, I mean, recently a study published in Health Affairs showed that Medicare Advantage enrollees are actually more likely to get a cognitive assessment. So again, this is a good opportunity to increase that number, and it looks like Medicare Advantage is a great place to do it. Next slide, please. So just case in point, you know, if you look far to the right on this slide, we talk about the assessment of Alzheimer's, and mostly what happens is if there's normal cognitive function, I'm talking about people over 65 now where this benefit is mandated. If you're over 65, you don't have any benefits, that's where the conversation ends, or you don't have any symptoms, I should say. That's where the conversation ends. That's the end of the ball game. And we might suggest that there's an opportunity here for a conversation around risk reduction, that there's an opportunity for a structured cognitive assessment that creates a baseline to measure change over time. One can argue that if the whole system was doing this better from the beginning, we'd have better data, for example, on COVID right now, and cognitive impairment as well, but we have not. It's not something that is consistently done or tracked. Next slide, please. So just to summarize, the evidence for risk reduction is pretty strong, and there's an opportunity, we think, to delay onset and increase function and potentially save money. Risk factors are connected to other chronic conditions, so addressing them helps other issues like diabetes and hypertension. People are more likely to make healthy choices and reduce their risk if they knew that it was connected to brain health and memory. People and providers want more information about brain health and believe assessments are important. There are existing incentives and opportunities for innovation within Medicare Advantage, and all of this is good for people, for families, for Medicare, and for the economy. So I'll stop there. Thanks so much.
Thank you, Kelly. A lot of useful insights there. Let's turn it over to Sandy for our final panelist presentation.
Great. Thank you so much, Greg. And again, thank you to the Better Medicare Alliance. And what a thrill to be on a panel with John and Kelly and the great information that they've given you. I'm coming at this panel from a little bit of a different perspective. As Greg said in my introduction, I am the CEO of USAgain, formerly the National Association of Area Agencies on Aging, and my membership are the 622 area agencies on aging, and also we're the voice in Washington for over 250 Title VI tribal aging programs. And collectively together, these 1,000 organizations provide a range of home and community-based services to older adults, more and more people with disabilities, and also supporting their caregivers across the country, with the goal of keeping people living at home well, safely, and independently as long as possible. And that is an important issue when we think of dementia. So next slide, please. So when we're looking at the issue at hand, I am going to be talking to you a little bit about the work of USAgain and area agencies on aging, but most particularly this afternoon about Dementia Friendly America, which is a national coalition specifically focused in on meeting the needs of people at the community level who are living with dementia and supporting their care partners. Next slide, please. So when we look at Dementia Friendly America, it was launched in 2015 as part of the White House Conference on Aging. And the goal is to really catalyze communities to be able to respond to the needs of people living with dementia and also to support their care partners. It was modeled after a very successful pilots in Minnesota, Act on Alzheimer's, which were led by area agencies on aging, but involved hundreds of community organizations and also healthcare organizations as part of that effort. And in addition to Dementia Friendly America, which is community-based, I'll also be talking to you a little bit about another initiative, Dementia Friends USA, which is more individually focused. But again, USAging is the fiscal agent for Dementia Friendly America. But this is a collaborative effort that involves a number of different organizations that I'll highlight. Next slide, please. And these are those organizations. And this is just a sampling of them. When you look at who all came together to look at being able to support people living with dementia at the community level, you've got the healthcare industry. Banner Health really led a dementia-friendly community in Arizona. Looking at the pharmaceutical community, looking at local government agencies and the International Sheriff's Association. Also looking at all of the Alzheimer's groups, Alzheimer's Association and Us Against Alzheimer's. So we're so pleased to have Us Against Alzheimer's as a partner, as well as AARP and other aging organizations. So it's really a very diverse group of individuals and organizations that came together, but key on that list are people who are living with Alzheimer's or dementia and their care partners. And that's a critical aspect of Dementia Friendly America and Dementia Friends, is that we involve and engage people who are living with Alzheimer's and dementia and involve critically their care partners in everything that we do. Next slide, please. So you've heard a lot of statistics and about the numbers of people who are living with Alzheimer's disease and dementia in the community. But I think this one statistic I would really like to highlight, which is the fact that 80% of people who are living with Alzheimer's and dementia are living in the community. And they're living in the community for a long time. And when you're looking at that statistic, is also recognizing how many people are living in the community who are living alone in the community and certainly need support. And we're looking at 1 in 5 people who are living with Alzheimer's disease and dementia are living alone at the community level. So when we're looking at this statistic, it's how can communities support healthcare and support caregivers in ensuring that people can live well at the community level. John shared his story about his father who was living with dementia and his role as a caregiver. Well, I have, and as probably everybody who is listening in, had the experience with my mother who had dementia. And I'm an aging professional, right? I could find aging services and supports. But what I couldn't find, my biggest obstacle was taking my mom out into the community, was taking her to church, taking her to a grocery store, especially as her disease progressed. It made her more socially isolated. And we know about the physical and mental effects of that. But it also made me as well, because I was struggling to take her out into the community too. Next slide, please. And we've already heard, and John and Kelly both highlighted the fact that caregivers are the backbone of the long-term care system, and they are the ones that are really, in this case, really holding up and supporting people who are living in the community with Alzheimer's and dementia. But at the same time, as was pointed out, they're undergoing their own health impacts of their caregiving responsibilities, and those also have economic impacts on communities and this nation at large in lost productivity, but also increased healthcare costs, not only for the people who have the disease, but also for their caregivers. Next slide, please. So when we're looking at Dementia-Friendly America, again, existing since 2015, we now have over 250 communities that have formally applied to be a dementia-friendly community. And what does that mean? That means that they've come together, they've signed a petition saying that they are going to work and bring together key stakeholders in the healthcare community and local government and all of the different sectors of their community together, along with people who are living with dementia and their caregivers, to be able to create a system of supports that really help people who are living with dementia thrive, living, still remaining in the community. Next slide, please. So when we look at what is a dementia-friendly community, a dementia-friendly community is one that is informed. It is one that is respectful of people who are living with dementia and also supportive of their care partners. And when we're looking at this, it's recognizing that you are never completely a dementia-friendly community. It's something that you always need to be working on. Next slide, please. So this slide really shows you a range of, when we're talking about what is the community and who are the stakeholders that need to be involved. Well, healthcare is key and critical. And we have worked through the dementia-friendly communities with dental offices and hospitals and primary care physicians' offices to make the design of those offices more attractive to, and also more safe and less obtrusive for someone who is living with dementia, and also helpful to their care partners. But in addition to that, we have also promoted screenings, clinical trials, and also providing additional education and support. When we're looking at local government, we're looking at EMTs, recognizing that oftentimes they get called in to homes of people who are living with dementia and they don't know that. And their response would be, and has been, very different once they've had training. Same thing with police and fire. In fact, in Montgomery County, Maryland, which was one of our first sites, Dementia-Friendly America, when they became a dementia-friendly community, it was the first time that in this very large urban area that the fire and police department had actually even come together and done training together on serving a population. What they found through that training, it has also very much helped those agencies respond to children that have major cognitive issues, people with brain injury, children with autism. So, in looking at things from a population health perspective, also looking at the faith-based community and the importance that holds for people who have dementia, looking at residential communities across the board, bringing all of these people together to be able to address this important issue. Next slide, please. But it's also recognizing that, I just wanted to give you a couple of examples. Training faith-based communities, and we've done this in partnership with Us Against Alzheimer's and their faith-based initiative. Looking at collaborating, I said, with law enforcement on ID bracelets, and also training on how to interact with people who have an emergency who may be living with Alzheimer's disease, working with local hospitals and physicians to promote, again, early diagnosis and connection to community resources. Next slide, please. Looking at ways to identify and hosting memory cafes. Also, we've had a great deal of response from businesses who are looking at creating dementia-friendly businesses, changing their store layouts and training cashiers to be sensitive to the needs of people who are living with dementia, and also working with local restaurants who are actually now creating spaces within their restaurants and special menus for people who have dementia. Next slide, please. So as we look at Dementia-Friendly America, that is a community response to being able to support people who are living at the community level with Alzheimer's and dementia. But what we also heard is that there were individuals who wanted to step up and be ambassadors, who wanted to step up and do individual work, which is why we got the license from Dementia Friends UK to become Dementia Friendly USA. And now we have 22 sub-licensees in 22 states, and we have over 100,000 dementia friends who are working at the community level to be able to do outreach and support to people who are living with dementia. Next slide, please. So as we look at dementia support, why is US Aging involved? Why are area agencies on aging involved? Very, very quickly, it's because of the numbers of the people that we are actually serving. 74% of our members report directly having exclusive services for people who are living with Alzheimer's and dementia and their caregivers. All of their services are serving people who have dementia, but they have really targeted to, in 74%, to really serving people who have Alzheimer's and dementia, and also recognizing that over half of our members are serving people with early onset Alzheimer's disease. So these are the populations that we're serving, which is why we're involved and why so many area agencies on aging are taking the lead in this effort. Next slide, please. And in saying that, we are doing this work through funding that we have from the Older Americans Act, but also looking at funding from the healthcare industry, looking at Medicaid managed care, looking at state Medicaid programs, commercial health payers. And as you see down that list, and this is from data 2 years ago, also Medicare Advantage is stepping up and supporting the work that is going on at the community level around aging and dementia care as well. Next slide, please. In looking at the breadth of the work that's being done, it's around case management, helping to support pulling together all of the different resources and programs that individuals living with this disease need. And that's very important to their caregivers. Evidence-based programming, nutrition, transportation, caregiver support, all of the social determinants of health, pulling those together, organizing those, and supporting people who are living with dementia and their caregivers. Next slide, please. And as we do this collectively together. As we said, Dementia Friendly America is a collaborative. US Aging is involved because these are the people that we're serving every day. But in doing this work collectively, collaboratively, there is so much work that we need to do together to be able to build that bridge between the healthcare world and home and community-based services, and recognizing that health happens both places, but a lot of health happens within the home. And in looking at community-based organizations and stakeholders, we're the ones invited into the home, and we need to be partners in this effort, working together with you as well. So with that, I'll close and turn it back to Greg for questions.
Thank you, Sandy. Really appreciate, just on behalf of Better Medicare Alliance, I really appreciate your passion about this important issue and your leadership, and just really want to extend my gratitude and appreciation to all the panelists who have, not only shared their insights and perspective, but really shared, your personal experiences with this. And I think, everyone is touched by this issue, either directly or indirectly, elderly parent, grandparent, relative. And, it's clear to me that it's going to take a lot of effort to really get a handle on this very complex issue and the importance of partnerships and collaborations. And, certainly think that was a key theme from the presentations today. I know there is an audience Q&A, but let me just start with a couple, if I might, and maybe I'll start with you, Sandy, on your presentation, just kind of a high level. You talked a lot about, the important work of area agencies on aging, the Dementia Friendly America initiative. You talked a little bit about kind of the collaborations that are underway. I guess just a high level question is like, how can policymakers and stakeholders really support the great work that you guys are doing on the ground in these communities? And then maybe we could talk a little bit more specifically about the role that Medicare Advantage can play in supporting these important efforts.
Sure, Greg, thank you. In jumping in, I think that when we're looking at from a perspective, it's recognizing that we need to, we talk a lot about integrated care, but we also need to make sure And I think that with Medicare Advantage, there's an opportunity there and an example of how you can support and fund both the medical side of the equation, the clinical side of the equation, and then also the social services side of the equation, those important social determinants of health. And recognizing how those can come together. Because oftentimes, I will have to say, I hear it often, the social services, oh, you're those free people. Well, we're not free. I mean, to be able to provide an increased level of services and complex services to people who have dementia and their caregivers, takes support and energy and effort. So I am really hopeful from a policy perspective and from a partnership perspective with BMA and the Advantage plans that we can find more and more ways to support and fund and build collaborations that really tie in, again, that everything from screening and diagnosis that Kelly was talking about to really be able to support people as they go through that journey of Alzheimer's and dementia. And it is a journey, and for many people, it could be decades long. But we all need to come together to do that. And resources, collaboration, and partnership and commitment, I think, are key.
Thanks for that, Sandy. Really appreciate it. That's a good segue, I think, into kind of talking a little bit about just the important role of early intervention and risk reduction. And maybe Kelly could talk a little bit more about that. Obviously, screening and getting this cognitive assessment is so important. And Medicare Advantage plans, have been at the forefront of encouraging these assessments. I guess what excites you most about Medicare Advantage, about the potential to address kind of the early intervention, risk reduction, and how can we move the needle even more forward as far as increasing availability to these services, which are just so important. It's not preventing dementia or Alzheimer's, but it's been shown that these kind of risk reductions is a key fact here.
Yeah, definitely. And actually, I'll add to that, another thing that people often forget about in the cognitive assessment process is that not every sign and symptom of dementia is dementia. It could be a medication interaction. It could be a nutritional deficiency. It could be a hearing problem. There are many things it could be besides dementia. And so there are lots of reasons to get a cognitive assessment, and not all of them mean, we think you have Alzheimer's, right? It should be, we hope someday, as routine as blood pressure, right? It's just a check. And it would be helpful to have that routinely done so you could see your brain health change over time and catch things much earlier in the system. So I think I wanted to make that point because we often assume that assessment means dementia. That's not the case. It also, I think, provides an opportunity to have this broader conversation that we're talking about risk. And the thing that Medicare Advantage has that is unique, I think, is benefit flexibility. The opportunity to look at the risk and preventive services is challenging in fee-for-service. And it is easier in Medicare Advantage to look at this more holistically. And so that is an opportunity, I think, for us to run some really incredible models and to think about how to connect the dots around screening and risk. One example might be home-based risk assessments, right? Not every cognitive assessment has to take 40 minutes, and be on paper. There are digital tests, there are brief assessments, the 88 is something that can be done over the phone. It's 10 minutes or less. There are multiple opportunities to offer this in different settings that don't have to take up a primary care clinician's time, that I think Medicare Advantage can be an incredible testing ground for. Some plans are beginning to do this. I'd love to talk to more and learn more about different ways to do it. I think, to Sandy's point, there's opportunities to connect and refer people to community care so that the burden is not in the clinical setting, but rather they're being referred and connected to services in the community that can help them. So, I think those are a couple of points I would make. The last thing I would say is, from a policy perspective, we are very much advocating for something called the Change Act. Honestly, HHS could do this administratively, but we want the cognitive assessment that is mandated under the annual wellness visit of Medicare to be done with a validated tool and logged into the EHR. And so that is something that we are actively working on now that there are many tools, as I said, that can be done briefly, we think this is absolutely something that could and should happen.
Thanks, Kelly. I really appreciate that. Let's turn to Dr. Wiecha next. Just very impressed about the early results of your program and your partnership with Suresti. Maybe just a little bit higher level for our audience today, kind of like, and just I was struck by this too, is how did you pursue kind of caregiver support as kind of the primary focus? And then I think related to that, how do you think this program can help advance progress on improving health disparities?
Yeah, thank you for that. I think as I mentioned, and as we've heard as a recurrent theme today, the issues and challenges confronted by caregivers are really substantial. We know that caregivers provide a huge amount of support particularly for community-based patients and health plan members who are living at home or in the community. And often those caregivers really don't have a lot of support. So the Suresti model, I think, is really unique in that it can impact the health of two different individuals, both the caregiver and the member or patient with dementia. I also wanted to point out, I didn't mention during the presentation I gave, we also have some preliminary evidence coming out now that the healthcare utilization and the costs of healthcare for the caregiver also appear to be lower among those caregivers who are utilizing the Suresti system. So we're seeing interesting preliminary evidence that utilization and cost for both the member and the caregiver are being reduced through participation in this pilot.
Oh, that's very compelling. Thank you. I know we do have some audience questions, so let me just click over here. Oops, that's the chat box there. Let's go. Okay, so the chat box is empty. Let's go with a couple more questions. I know we have about 4 minutes left. Let's talk a little bit about kind of public policy, and this is to you, Sandy. And you talked a little bit just about the important work of area agencies on aging and funding. But from a public policy perspective, kind of what could Washington do? What could Congress do to kind of help support your initiative on making these communities more dementia friendly?
Well, thanks. And I think that we're really hopeful and that right now we have conversations going on within the Department of Transportation, within the Department of Housing and Urban Development around age-friendly communities and dementia-friendly communities, and looking at how to incorporate these issues into the planning and programming that they're already doing. So I think that that's, and the more that we can do that as legislation gets developed, looking across the board. But I really think, the work that is being done by CMS in around integrated care and the different pilots around how to involve community-based organizations and community-based planning is key and critical. And I'll be honest, I think part of this is really, again, building on the example of the supplemental benefits, is in enabling this not to be just an exception, but really incorporating and recognizing, if we recognize the social determinants of health are such a driver of health, then we should find ways to pay for them. And I think that the closer we can move in that direction, the more that we will actually strengthen that bridge between acute care and home and community-based services. And who is going to benefit? It's going to be the patient. It's going to be the caregiver, but also I think, as you've heard in the discussion today, it makes economic sense to do this as well.
In other words, it's both humane, but also kind of cost effective as well. as far as providing these type of services.
Yes.
And I think you're exactly right. This does align very well, I think, with the kind of the strategic priorities and direction around, making care more patient-centered and care in the community and really reaching, these underserved communities. So all excellent points. Maybe, I think we have 1 minute left, maybe just like 30 seconds each about, what's the most important thing, I think, for this audience to know about this issue and your work, and how can we continue this conversation going forward?
Oh, that's a big question in 3 seconds. But I want to just say one thing I would be remiss in saying is I think one of the biggest policy priorities we have right now, is apropos of this conversation, is paid family leave. Like, this is on the Hill at the moment right now, and we really need paid family leave. So caregivers are unpaid, and as we've heard, it's an economic issue. And so that is one of our big policy priorities that I think and urge everyone to support.
Very important.
Also, yeah, and we also I think one of the important things for the Medicare Advantage audience, I guess, to know would be that we think there is a lot of opportunity to address risk and potentially delay the onset of dementia, and would very much like to advance those conversations and hear more from people about what innovative things they are doing on the ground. So that would be my big takeaway. But on the policy side, I think paid family leave, the Change Act, early screening. We're advancing a national dementia prevention goal to urge the Secretary of HHS to make this a bigger priority when he thinks about how to address Alzheimer's, and a number of other things, but those would be top of mind.
Thank you, Kelly. Sandy, 30 seconds.
30 seconds. One of the reasons why people aren't getting diagnoses from their doctors was because they didn't think that there was any help or support, and there is at the community level, so let's invest in it.
Excellent. Dr. Wiecha, last word.
Well, I think, again, thank you for having me. And I think Point 32 Health is such a great example of how a Medicare Advantage program can provide support, innovative programs to members at risk for dementia or have dementia. We have a number of additional supplemental benefits that we provide to address the risk in this area. We have a dedicated dementia care coordinator program with 2 FTEs that are physically sited with the Alzheimer's Association of Massachusetts and New Hampshire. So I think Medicare Advantage is such an important example of an effective approach to addressing these programs. We need to continue to provide support for Medicare Advantage.
Thank you, John. And thanks to all the panelists. Really appreciate your insights and perspective here. And that concludes this session. Thank you.
Thank you so much.
Thank you.